You suspect your patient has meningitis. You need to measure cerebrospinal fluid pressure. Your patient requires an injection for a myelogram. Each of these could be an indication for a lumbar puncture. The lumbar puncture is one of the easiest procedures to perform, but you must know the indications, risks, and possible complications. Diagnosis is the most common indication. Measuring cerebrospinal fluid pressure can be useful for determining the etiology of a headache. Injections are a third use, for myelograms, anesthesia, or intrathecal chemotherapy. The only absolute contraindication to a lumbar puncture is infection of the overlying area. Relative contraindications include increased intracranial pressure or a bleeding abnormality. Generally, patients with a platelet count of 20,000 or more can safely undergo an LP. You will need to explain the procedure, reviewing the risks and benefits as well as complications. Be sure to ask about allergies to lidocaine and topical betadine. Patients may relate stories about others who have become paralyzed from an LP. Explain that patients like those usually have an underlying illness, such as polio or Guillain-Barré. The lumbar puncture is a safe procedure. What are some common risks? Infection, so make sure the area is cleaned thoroughly. Bleeding is another risk. Make sure your patient is not taking anticoagulants and does not have a medical condition, such as liver failure, that would make bleeding likely. If the platelet count is under 20,000, plan to transfuse platelets either just before or during the procedure. Finally, the needle can stimulate regional nerves, causing paresthesia. If the patient shows any discomfort, remove the needle and wait until it resolves before resuming the procedure. There are several possible complications from this procedure. Headache, characterized as throbbing in the frontal or occipital areas, or both. It can be associated with visual, auditory, and vestibular symptoms due to traction on the cranial nerves. Headache generally occurs less than 48 hours after the procedure in roughly 10 to 30% of cases. If a headache occurs less than an hour after the procedure, another cause should be suspected. 75% of the time, it resolves within 7 days. Treatment is to have the patient lie recumbent for 6 to 12 hours and to encourage PO intake. Additionally, analgesics or caffeine at 300 milligrams PO Q6 to 8 hours, or 500 milligrams of sodium caffeine benzoate in 500 to 1,000 cc's of normal saline IV over 2 to 4 hours can be used. Caffeine is effective in 75 to 85% of cases. Paresthesia, if present, generally occurs transiently during the procedure. If it continues, a nerve root has probably been impinged upon. This would indicate that the needle position is too lateral. Other complications are tonsillar herniation, meningitis, CSF leaks or hematomas, subarachnoid, subdural, or epidural. The last three complications seldom occur unless the patient is anticoagulated, thrombocytopenic, or has severe liver disease. There will be some differences among procedure trays, depending on the manufacturer. A typical tray contains a 2-piece manometer, a 21-gauge deep infiltration needle, an ampule containing about 2 milliliters of 1% lidocaine hydrochloride, a 3 cc plastic syringe, a 20-gauge spinal needle with stylet, and a 25-gauge skin infiltration needle, 4 numbered sample vials, a bandage. In this kit, it is beneath 2 prepping applicators, gauze, extension tubing, a cover, a fenestrated drape, and betadine. Unless you are familiar with the kit contents, you should also obtain sterile towels, extra gauze packages, extra betadine swabs, at least 1 extra package of gloves in case contamination occurs. Kits contain at least 4 sterile vials, but at times you may need extras. Consider an extra syringe and 18-gauge needle. Although most kits contain 1% lidocaine, we recommend using a 2% solution. Pain is a common complaint with injection since the lidocaine stretches the skin. The smaller volume required by 2% lidocaine causes less discomfort. You will need protective equipment as required by OSHA. Don't forget a trash can. The spinal cord starts at C1 and ends at the level of L1, L2 as the conus medullaris, and is secured to the coccyx by the filum terminale. From the region of L2 to S2, the subarachnoid space of the spine forms the lumbar cistern, which contains cerebrospinal fluid. The nerve roots emerge laterally through the intervertebral foramina. Since the needle will be placed caudal to the termination of the spinal cord, there is little danger of paralysis with the lumbar puncture. For a lumbar puncture, the interspace of choice is L4, L5. The spinal cord has terminated by this level, and the interspace height allows easy access to the cistern. Other possibilities for an LP are at L3, L4, and L5, S1. Levels above L3 are not desirable, since the nerve roots are more likely to be in a fixed position rather than free-floating. Areas below S1 are difficult to penetrate, since the vertebral bodies of the sacrum are fused. A lumbar puncture penetrates these layers: the skin, the supraspinous ligaments, interspinous ligaments, and ligamentum flavum, then the epidural space, the dura, the subarachnoid membrane, and finally the subarachnoid space, where CSF is obtained. The interspace, which is the target for the LP, is the space between the two vertebrae. This interspace is protected by the long spinous processes, which, in the cervical and thoracic spine, overlap each other. Going down the spinal column, the processes shorten, making the interspace more accessible. Flexing the spinal column further widens the interspace. When doing an LP, palpate the end of the spinous process and enter there. This entrance gives the greatest accessibility to the cistern. Aim 10 to 30 degrees cephalad. As shown here, you could almost go perpendicular. There are two acceptable positions for a lumbar puncture. In one, the patient lies in a lateral decubitus position, either right or left. In the other, the patient sits upright at the edge of the bed, leaning forward. Either position is acceptable. Before beginning, be sure to check the patient for papilledema, using an ophthalmoscope, or for mass effect with a CT scan. The decubitus position allows maximal flexion of the spine while keeping it aligned. Raise the bed as needed so that you are comfortable and can visualize your field. Make sure the light is adequate. Place your patient in the lateral decubitus position with the back close to the edge of the bed. The shoulders and iliac crests should be in perpendicular alignment to the spine. To help with this, put a pillow under the patient's head so that the external occipital protuberance and the spine are in the same horizontal plane. Flexion of the neck is not of great value here to heighten the interspace. Pillows can be placed between the knees to assist in keeping the iliac crests aligned. Double-check to make sure you have everything you need. Have the patient draw his or her knees up to the chest to widen the spaces between the spinous processes. Use this method to find your target site. The advantage of using the upright position is in the ease of access to the landmarks and site with minimal need for patient cooperation. Patients who are obese, have breathing disorders, or who have obscured landmarks may benefit from this position. Place the patient upright, preferably leaning against a table. Make sure the table can't move. Give the patient a pillow for comfort. Be sure that the patient's shoulders and iliac crests are perpendicular to the spinal column. A foot support and pillows may be needed to elevate the feet. Your objective is to create the fetal position with the patient upright. Review your landmarks. Palpate the iliac crests. Come midline and palpate the interspaces. This is your target spot, L4, L5. Put on sterile gloves and continue as previously demonstrated. Draw an imaginary line horizontally between the iliac crests. Bisect the line with the spinal column. Using the landmarks, find and palpate the interspace. Once you have determined your entry point, Reduce the chance that the patient will tire by letting the patient relax while you set up. Be sure that the equipment is set up for easy access. If you have no assistant, set up as much beforehand as possible. For example, open the cap of the lidocaine, open extra gauze packages, put on sterile gloves, remove any excess material from your field, and set up the vials. The bevel should always be pointed cephalad with respect to the patient. Examine the spinal needle. The stylet should move in and out easily. The needle should be tapered with smooth edges. Spinal ligaments run in a longitudinal direction. With the bevel up, the narrowest part of the needle will initiate the opening, which will separate the ligaments smoothly, and on removal, the ligaments will seal tightly. Now assemble your manometer. Make sure the adapter is in place. Break the top off the lidocaine with some gauze and draw it up. If you will be using 2%, have someone assist you with drawing it up. If no one is able to assist, use the sterile gauze to release the needle. Dispose of the contaminated gauze and attach the 25-gauge skin infiltration needle. Keep the patient informed.
Keep in mind that your back will be a sterile area, so try not to touch it, okay?
When cleansing, always start in the center of the field and work outward in a circular pattern. Repeat this for a total of 3 passes. If you run out of applicators, use gauze. Drape the field.
I'm going to start numbing your back. Some patients say this feels like a bee sting or just a little bit worse.
This stinging pain is caused by stretching the underlying tissue. However, by stretching the skin before injection, you stimulate the skin's sensory receptors, so numbing will seem less painful. Once the skin has been numbed, use the 21-gauge needle to infiltrate deeply. Anesthesia should last about 20 minutes.
Are you doing okay? Now I'm going to start numbing deeper.
Aspirate before injection to assure that you are not in the subarachnoid space or in a blood vessel. The spinal cord is highly vascularized by the anterior spinal, the posterior spinal, and the radicular arteries. When numbing with lidocaine, place the needle all the way in, then slowly back out while infusing. Since the patient feels pain on insertion, this works better than making many small thrusts, numbing as you go. After numbing, recheck your landmarks. Place your hand at the bottom of the spinous process. Mentally note this spot. You want to enter here. Here at the tip of the spinous process, you will need only a small entry angle, 10 to 30 degrees, depending on how flexed your patient is. The most common error is failure to enter just below the spinous process. If you are too far below the process, you will hit bone regardless of the angle.
I'm getting ready to start. Let me know if you feel any pain or any kind of numbness or tingling.
Place the needle between your index and middle fingers with your thumb on the back of the stylet. Now seat the needle. Advance the needle, directing it at an angle 10 to 30 degrees cephalad, aiming toward the umbilicus. Be sure that the bevel is up, so the ligaments will be separated rather than sheared. If you think you are in the space, withdraw the stylet to confirm that CSF flows freely. If not, continue to advance the needle. The stylet does not have to be replaced. There is very little tissue in the area to clot the needle, and there is a low risk of symptomatic air introduction. The cistern should be reached within 3 to 6 centimeters.
We're in. Now please straighten your legs slowly.
Opening pressure should be obtained immediately after entering the subarachnoid space in the decubitus position. Attach the manometer to the needle and measure the opening pressure. The legs must be extended for this measurement to be accurate. Be sure the pressure has equilibrated for 15 seconds. Observe for respiratory variation. After obtaining the opening pressure, remove the manometer and begin collecting fluid.
I'm going to start collecting the fluid. Are you doing all right?
Some CSF will be lost from the manometer. Fluid can be collected in two ways. One is by connecting the extension tubing. The other is to place the collection vial at the end of the stylet and let the fluid drain into it as demonstrated. If you are going to use the extension tubing, make sure the caps are on tight. Connect the distal end of the tubing to the cap to collect the fluid. Fill the vials in numbered order. You will need about 1 cc for chemistries such as protein and glucose. Cell counts, cultures, and cytology each require about 3 cc's. Use the fourth vial to collect 3 cc's for backup. Once you have the samples, if a closing pressure is indicated, reattach the manometer. If not, remove the stylet. Apply pressure to seal the tract and aid hemostasis. Check for bleeding or CSF leakage. Remove the betadine. It can irritate the skin. Apply the Band-Aid. Ask the patient to lie supine for 30 to 60 minutes. After your samples have been collected with the extension tubing in place, attach the syringe containing the chemotherapy. Keep in mind that the syringe is not sterile. You will inject about 1/2 cc of chemotherapeutic solution, then withdraw about 1 cc of fluid. Repeat it over the course of several minutes. This allows mixing of the agent and CSF. Keep your patient prone for 1 hour after this procedure. Studies have shown that this promotes a higher concentration of chemotherapeutic agent in the CSF.
What are some technical problems encountered when doing a lumbar puncture?
The most common is incorrect positioning. The goal is to have the spine aligned, perpendicular to the shoulder and iliac crests, while having the spine maximally flexed. Do not guess your landmarks. Palpate over and over until you feel comfortable. Don't be intimidated by more experienced observers. This is your time to learn and gain expertise. Is your patient maximally flexed? If not, the interspace will not be opened adequately. Be sure that you palpate the spinous process. This is key to entering the interspace. If you enter the middle of the interspace, you are destined to hit bone. Entering just below the process increases chances of entering the interspace with minimal need to angle your needle. You could almost enter the interspace by going perpendicular.
What if you do hit bone?
Consider whether the needle is off the midline. Make sure you are not too far below the spinous process. You should be directly below it. Confirm that you are directing your needle 10 to 30 degrees cephalad. If you are unable to ascertain the problem, withdraw the needle and start again. If you are still having difficulties, consider whether your patient has scoliosis. Lateral curvature or rotation of the spine can make an LP technically difficult. Confirm that the patient has had no back trauma or surgery that would require use of fluoroscopy.
What if your patient is dehydrated?
Dehydration will slow the flow of CSF. Consider hydrating your patient or using a larger bore needle to enhance flow. If you are unable to obtain CSF, consider whether the needle is obstructed. Inject with 1 cc of air to dislodge any obstruction. If no air or CSF returns, then you are probably in the epidural space and need to advance.
What if you've entered the space and fluid stops flowing?
The needle may be too far in or out. Chances are you have overpenetrated. Withdraw the needle slowly, or rotate it. Membranes or nerve filaments may obstruct the flow.
What if you have an obese patient?
Use the upright position if feasible. It will allow you to better palpate landmarks. It is possible that you will place the spinal needle all the way in and still not get CSF. Obtain a 16-gauge spinal needle to use as a guide. Seat it. Place the longer 18-gauge needle through the larger bore 16-gauge needle and proceed. Consider the collected samples. Be sure they are tightly sealed. It is important to know the order of the vials. The first collected vial should not be used for a complete blood count because results can be factitious from procedural contamination. Put on another set of gloves since your sterile pair will have body fluids on them. These gloves do not have to be sterile. Labeling goes more smoothly if you remember to have labels printed ahead. Vial 1 is best sent off for chemistries. On your order sheet, write Vial 1, glucose and protein. Don't forget to obtain a concomitant serum glucose. Vial 2 is sent for bacteriology, specifically for gram stain and culture. If you suspect meningitis, request a bacterial antigen panel. Use Vial 3 for cell count and differential. Vial 4 can be held for a variety of other tests, depending on the clinical setting. Make sure you label these vials yourself and ensure that they are sent promptly to the lab. What do your results mean? First, consider the color and clarity of the CSF. Normal CSF is colorless and clear. Turbidity could indicate infection. A pink tinge or bloody appearance signals hemorrhage. Normal pressure is between 70 to 180 millimeters of water. Normal protein concentration is between 15 and 45 milligrams per deciliter. Normal glucose concentration is 45 to 80 milligrams per deciliter. That is 2/3 of serum glucose. If white blood cells are present, they will be between 0 and 5, predominantly lymphocytes. RBCs should be 0. Bacterial infections produce normal to elevated opening pressures, elevated protein, and low glucose. White counts range from 5 to thousands. They are predominantly polys. Aseptic meningitis produces normal or occasionally elevated opening pressure, elevated protein, and normal to low glucose. White count is elevated, polys in the early stages, then predominantly lymphocytes. These results can overlap. You will need to consider the clinical setting. Reference tables can be found in books like this one. What are some panic values? A highly elevated white blood count should alert one to meningitis. The key here is to start antibiotics. If you are suspicious of bacterial meningitis, antibiotics should be hanging so that once the LP is done, they can start infusing. If the LP cannot be done in a timely manner, then start the antibiotics without it. An elevated RBC count can indicate hemorrhage. In this case, consider your clinical setting. Try to determine from which vial the sample was run. Recall that the first vial should be avoided, since it can be contaminated by the trauma of the procedure. If the elevated count does come from the first vial, run another vial to see the pattern of the counts. Most traumatic taps should clear with progressive collection. If no variation is seen, the tap may still be traumatic. Immediately centrifuge the CSF. It will be colorless in a traumatic tap, but xanthochromic if hemorrhage has occurred. If there are no other untested samples available, rerun what you have, or consider retapping. Included in the workup of suspected hemorrhage should be a good neurological exam and head CT without contrast. If any of these tests indicate a bleed, a neurosurgical consultation should be obtained. The lumbar puncture is one of the easiest procedures to perform. You must know the indications, risks, and possible complications. Checking for papilledema is essential. Make sure that you and your patient are comfortable before starting. Have all materials on hand. Be sure to position your patient correctly, spine aligned, shoulder and iliac crests perpendicular. Enter just below the spinous process. Label the samples in order. After checking your patient, follow up on your results and be sure to document the procedure thoroughly.